Thank you, Mintu. So, welcome everyone to the third edition of the Endocrine Nursing Symposiums that we have been doing on behalf of the Endocrine Society of India. And I think we wanted it to be coinciding with World Diabetes Day, but unfortunately, as you're all aware, that is the day we are having the festival of Diwali in India, and that is the reason why we had to prepone it by a couple of days. I think the theme for this year's World Diabetes Day is the importance of nurses in the management of type 2 diabetes. So I'm very glad that the first event that we are doing coinciding with the World Diabetes Day as from Endocrine Society is a nursing webinar. So I'll now ask Dr. Suresh to introduce our chairperson.
We are privileged to have President of Foundation of European Nurses in Diabetes from United Kingdom, Anna Mary Filton. She is a former diabetes nurse specialist, a diabetes clinical nurse manager at Queen Mary University Hospital, London from 1980 to 1996. Co-founder and pro bono president of Foundation of European Nurses in Diabetes from 1996 to till date. She is a trustee at Diabetes in United Kingdom from 1989 to 1999. The co-chair at Vincent Task Force United Kingdom Education and Training in 1995. Vice President, Diabetes United Kingdom, and WHO consultant continuing education for healthcare providers, prevention of chronic disease, and therapeutic patient education between 1997 to 2000. Joint chair diabetes in policy puzzle education between 2005 to 2014. Vice president of IDF between year 2006 to 2012. Chair of organizing committee IDF World Diabetes Congress in Melbourne in 2013 and in Vancouver 2015. She has presented numerous papers in different conferences globally. Few to name: the UN Summit on NCDs, a turning point for diabetes in EDWG EU Parliament Business in 2010. Diabetes in Europe, key priorities for European institutions in EDWG EU in 2015. Diabetes in Europe, the state we are in IDF World Diabetes Congress in 2015. Evolving role of diabetes nurse specialist in 28th conference in Spain Society of Diabetes. And there are many more into list. There are numerous awards to her credit. Few to name here: Janet Kinson Education Award in Diabetes in United Kingdom in 1996. Honorary member, Polish Federation of Diabetes Education 2015. Honorary member of EASD in 2015 and Ambassador for Diabetes in United Kingdom in 2018. And Harold Rifkin Award for Distinguished International Services in the Cause of Diabetes by American Diabetes Association in year 2020, which is a year announced by WHO and ICN for nurses and midwives. We are privileged to have Annie Mary Filton with us today, and I request her to give us a keynote address on this important event of the month, which is 14th November, the World Diabetes Day. And as Dr. Jacob said, that the theme is very apt this year. The year 2020 is for nurses and midwife, and IDF have identified that diabetes, the nurses and nurses can have a good impact. So we are privileged to have Anna Mary, and I request her to unfold the keynote address on the day today. The 2 days ahead we are celebrating it, and then introduce the speakers. Welcome, Anna Filton.
Professor Sharma, thank you so much for the very warm welcome, and really the privilege and honor is mine in recognizing both the Foundation of European Nurses in Diabetes, but also in your own professional capacity in recognizing the contribution that nurses make generally to healthcare globally, but in particular to the cause of diabetes care, research and education, because undoubtedly it is a global pandemic. And we have at the moment, as you know, two pandemics colliding. And the great fear is that diabetes can be sidelined because of the challenge of COVID. And it is all of our responsibilities to make sure that diabetes is not disadvantaged any more than it already is. So thank you so much for the opportunity to share with you this very important day. And congratulations to the Endocrine Society of India for embracing so nobly and so publicly the role of endocrine nurses in diabetes. This is a significant milestone. And I hope that your partnership with the profession of nursing and nurses working in the specialty of diabetes will continue to flourish, because none of us can do this alone. So without further ado, I also wish to, before I move on, to thank Professor Jacob for formally inviting me on behalf of the Endocrine Society of India and the Endocrine Nursing Society to participate in this meeting. He has been very helpful. He is very demanding, so I'm not surprised you are so very successful. That is not a criticism. I know what it is to be demanding, so many congratulations. Undoubtedly, the subject of this symposium today is of paramount importance. There is an old song, "These feet were made for walking." Can we be sure that with the condition of diabetes, that every person with diabetes, through our good work and their self-management, will continue to walk? And how can we be sure that our prevention interventions, and in the event of complications arising, can be minimized? It is a particular challenge indeed, and the role of nurses and the contribution that they made from a scientific evidence base is of huge importance. So I do welcome our first speaker, who is, and I must get the name correct, is Flori Christina. Flori, thank you so much. We have met briefly beforehand, and following on from Flori will be Bharatha Saravana. Both are nurse specialists in diabetes with a particular interest in the complications of diabetes as it relates to the foot. And I don't think I should take any further time speaking, because it is their contribution that we are eagerly awaiting. Following on from their presentation, we have an illustrious, dare I say, a veritable constellation of talent in the panelists. And I know that this will be chaired by or moderated by, I think, Professor Jacob, but there may be some changes in that. One of the great beauties of these sort of present seminars, so to speak, is that we can all be flexible. So welcome, and may we have our first speaker, Flori.
Good evening, everyone. Thank you, ma'am, for your kind words of introduction. And I'm very glad, and I would like to thank the organizers for making me a part of this event today. And with no much delay in time, I would like to share my presentation with you. So, foot care in diabetes.
Please click share screen.
Yeah, sure. Is my screen visible to everyone?
Yes, we can see.
Yes.
Yes. So foot care is a very essential part of self-management in diabetes in our patients, as improper foot care can be, I'm sorry, I'm having a difficulty to change. Yes. So as we see in this picture, so every single patient whom we see in our OPD with diabetes, this may be the future of them when an improper foot care is there. So foot care is an essential part of self-management of diabetes in every patient, as an improper foot care can cause a risk of losing their feet and losing life as well. So, as we all know, diabetes is a leading cause of non-traumatic lower limb amputations. And over a period of time, when patients have uncontrolled diabetes, it might lead to peripheral neuropathy. And in duration of time, with increased pressure to the feet, with loss of protective sensation causing injuries, and these injuries can cause ulcers which are not healing for a long time, might get infected, ischemic, and further leading to amputations and associated complications with death. So all we with this burden in here at the Department of Endocrinology and Diabetes, we work as a team of endocrine physicians, PMR physicians, prosthetic and orthotic technicians, vascular surgeons, physiotherapists, and diabetes educators in handling patients with diabetes and foot associated problems to prevent foot care issues. So foot care can make a lot of difference between saving a foot or losing a foot and life. So it is our responsibility as nurses, as we see every single patient in our OPD with diabetes, either it is newly diagnosed or they've been having diabetes on a long term. It is important for us to teach these simple steps in foot care to our patients. That is to check, wash and dry their feet regularly, use appropriate moisturizers, protect their feet, and regular follow-ups. So a simple foot examination as a basic for every single patient whom we see has to be taught, which they can perform by themselves on a routine every day. A foot inspection should cover the whole area, including the dorsum of the feet, the sole, the heel, and the nails and interdigital space. So what can we look for? We look for any obvious deformities as we inspect the feet, look for any swelling, any blisters that are there, any nails that are ingrowing and pricking through the skin, any prominent veins, any obvious color changes, any callosities or corn, any thickening of skin under the feet, any skin breakdowns, any fissures, or an ulcer that is not healing a long time, a sore, or any discharge from the ulcers that are present. So our patients can be advised to use a small mirror, as we say in this picture, to just look at the dorsum of their feet and the plantar aspect to see if they're having any obvious deformities. So there are some areas which we have to look at when we teach our patients with a high risk of having ulcers. So as we see in this picture, the prominent pressure points, and for patients who have obvious foot deformities such as low arch feet or a high arch feet, the pressure areas and the interdigital pressure increases with inappropriate footwear, which might cause toe deformities, and there is a risk of foot ulcers over these areas. So the majority of foot ulcers occur over the toes on the metatarsal heads as a pressure points. And as we see, these are some of our patients who've been suffering with such ulcers and it's been non-healing for a long time. So as we see here in this picture, so this is a toe ring one of our patient is wearing, and this is a very common culture back here in India. So every patient, a married woman, you see they'll be wearing a toe ring. What happens ultimately is that when they don't concentrate on this much and the feet get swollen or the toe gets swollen, in a peak of time, it might cause an ulcer, which is non-healing and might lead to amputations. So advise every patient who wears a toe ring. Some patients may not be willing to do that, but it is important that we tell our patients to either wear a loose ring or remove the toe rings to prevent ulcers. So appropriate footwear can make a major change in the patient's foot. So if the footwear is too tight or if it's too loose and if it doesn't accommodate the feet well, it can cause obvious foot deformities such as a hallux valgus and ulcers over the toes, which can cause a non-healing ulcer and amputations. So this is a T-strap footwear, which is again a very common footwear worn by most of our patients on a very long period of time. Patients who are having loss of protective sensation to their feet, who do not feel a footwear in their legs, they try to hold these footwear every time, and as we see a lot of pressure over these areas, over the toes, which ultimately causes ulcers over these areas and causes toe deformities such as hammer toes, mallet toes, and claw toes, leading to ulcers. So again, cross-leg sitting is a very common practice here in our country. So what happens ultimately is when patients sit on a long time with their legs crossed, they might have developed ulcers over the lateral malleolus, which might be unhealing, and this takes a very long time to heal. So we advise our patients not to sit cross-legged and use a chair. And if patients are at work where they have to be sitting on a long term folding their legs, they can be advised to use a small padded cushion or a sheet folded to prevent ulcer over the malleolus. So regular washing of the feet, like just how we take care of our face. So advise our patients to wash the feet every day with soap and water, dry them carefully between the toes. For dry skin patients who suffer dry skin because of neuropathy, it is good for them to soak their feet 15 to 20 minutes in lukewarm water and use a nylon scrubber to scrub the hard areas to remove any debris. So use of moisturizers every day is advisable. Again, when we suggest our patients to use moisturizers, it is really important for us to know where the locality of the patient is. We had history of patients who have been using coconut oil as moisturizers, and they've had landed up in rat bites and ant bites and come with ulcers to us. So it is really important for us to advise our patients to use appropriate moisturizers to prevent dryness of the skin. And trimming of the nails, again, is a common practice for people to use blades. So we advise patients to trim their nails with nail cutters in order to prevent injuries. And trimming of the nails should be straight and not across to prevent ingrowing toenails. So interdigital space hygiene, again, is a very common concern, as fungal infection is very common in patients with diabetes. So teach our patients to examine between their toes to see if there are any obvious fungal infections. Keep the area dry and clean by cleaning the area after washing the feet with a dry cloth. Use antifungal treatment if at all it is necessary, if there is an obvious fungal infection is present, and use a wider toe box shoes so that the pressure over the toes, like the toes are not crushed into the footwear, which might cause to fungal infections. So patients must be taught to avoid barefoot walking, as the loss of protective sensation is there. Patients might land up having small injuries which may not heal in time, leading to ulcers. A proper fitting socks, preferably cotton socks, in order to make sure that the socks is breathable and it's not too tight or loose, causing blood circulation, impaired blood circulation to the feet. And avoid wearing T footwear, and an ideal footwear must have a proper back strap, and an MCR footwear is advisable for patients with diabetes. So apart from this, a good glycemic control contributes to prevention of foot ulcers. So our patients can be taught the simple monitoring of their blood sugars can be remembered as A, B, and C. A is to monitor the HbA1c every 3 months, which has to be less than 7, maintain a blood pressure of less than 130/80, and have a complete screening for their complications for any early foot problems or problems in their eyes and kidneys. So a simple clinical foot examination to all our patients who come to our OPD is mandatory in order to early identify foot problems in patients and prevent foot ulcers. So this might include just a 2 to 5 minutes of simple inspection of the feet to see if there are any obvious deformities, palpation of the peripheral pulses, and an objective examination using certain tools and instruments. So a monofilament, these are like nylon filaments which are used to assess the loss of protective sensation. They are available as 2 grams, 4 grams, and 10 grams. And these are the areas recommended to test these monofilaments. So any person is tend to have a complete loss of protective sensation if they are not able to perceive a 10-gram monofilament. So a biceciometer is similar to that of a tuning fork that we use. This is used to assess the vibration perception threshold. So this helps us to quantify the amount of vibration perception that the patient has. It is said to be normal if the patient is able to perceive a vibration sensation of less than 15, and it's considered mild when it is 15 to 25, and we consider it severe when it is more than 40. So again, a durometer is an instrument that is used to test the shore value of the footwear the patient wears. So the hardness of the footwear always matters, because this again gives a counter pressure to the leg, causing foot ulcers. So an ideal shore value of a footwear should be between 8 to 15, and a recommended footwear is a MCR footwear with a soft sole. So here at the Department of Endocrinology, Diabetes and Metabolism, training is given to healthcare professionals in the area of foot care, where they are trained to do minor procedures such as callosity removals, corn removals, and teach our patients on foot care related aspects. Here you see one of our nurses doing a foot care procedure, and the aspects of offloading in integration with the PMR department is being addressed to our patients to prevent foot ulcers. So as we all agree that prevention is always better than cure, a thorough education on foot care to all our patients who come to the OPD, may it be a new patient or a patient who's on a regular follow-up, and a regular follow-up of these patients doing a proper foot assessment might improve their compliance, leading to prevention of foot ulcers. So I want to thank you all for your patient attending. Any clarifications, doubts?
Thank you very much indeed for that really fascinating presentation. And I also want to congratulate you on the clarity of the diagrams and slides that you have presented here. Two things that have struck me coming from the UK. One is to bring to the attention the observations that you've made with regard to toe rings. Now, this is something I don't think we are conscious of. I mean, we may see them, but not think about it in the way that you have, and that's a very important message. And your observation or your advice in relation to moisturizers, and that certain moisturizers would not be advantageous to use, and I think this is another area. So thank you for bringing that to me. You mentioned durometers. I have to frankly tell you, I have never heard of this. And again, it is relevant. When I look at the foot fashions or foot shoe fashions in the UK and elsewhere here in Europe, it's really very, very important. So you are bringing a dimension that perhaps we are less conscious of, and as a consequence may not be serving people well in relation to the education that we provide. So thank you very much for that presentation and for the way in which you presented it as well. You clearly are a mistress of your specialty. Thank you.
Thank you, ma'am.
Okay, so moving onwards, as we say here in Europe, onwards and upwards, our next speaker is Bharata Saravana, who is a senior diabetes educator and charge nurse at the Christian Medical College, Vellore. Welcome, and I look forward to your presentation.
Thank you, ma'am. Thank you for that presentation.
Okay. Take your time. These things take time, and we have time.
Yeah. Is this
I'm
visible?
just very glad I'm not operating it. It would be a disaster.
Yeah. Is the screen visible from my side, ma'am?
Not yet.
Not yet.
Not yet, ma'am. Would you just click on share screen and then select your presentation?
Yeah.
Am I right? Okay, perfect. Full screen, please.
Yeah.
Thank you.
Yeah. So, good evening, one and all. At this outset, I would like to thank the organizers for giving us the great opportunity for sharing our knowledge and expertise among the nursing people. Thank you so much for the wonderful opportunity. And good evening, one and all. The topic for today is choosing the right footwear for patients with high-risk feet. So for the next 20 minutes, I would be taking you all through the different types of footwear which we give it for our patients and what are the modifications which we do it as a custom-made footwear. Diabetic foot ulcers are the most serious complications among the diabetic patients, and it is the leading cause of hospitalization for patients with diabetes. And it is also stated that 15% of persons with diabetes can develop foot ulcers in their lifetime. And it is a source of major suffering and financial cost for the patient. And also it puts the patient by placing a financial burden on the patient's family, to the healthcare professionals and the society as well. Now, the International Working Group of Diabetic Foot in 2019 has formulated the cornerstones on how to prevent the foot ulcers. Flory has given an excellent overview of how do we prevent the foot ulcers. The same thing, like they have given 5 cornerstones, where the first thing is we need to identify the risk feet. Second is we need to regularly inspect and examine the at-risk foot. Third is we need to educate the patient, family, and the healthcare professionals. Fourth is we need to make sure that the patient wears an appropriate footwear. The fifth is we need to treat the risk factors for ulceration. So the risk factors may be a toe deformity such as a claw toe, mallet toe, hammer toe, or the patient can have some callus formation. So these are the predisposing factors for any diabetic foot ulceration. So even that we need to address it. The IDF has given the methodology on how do we do a diabetic foot screening. So there are 4 categories, where the low risk category is where the patient has absolutely good sensation of the feet. We need to recheck them in 12 months. When the patient has loss of protective sensation, which is quantified by when the patient is not able to perceive a 10-gram monofilament. So we could recheck them in 6 months. When the patient has loss of protective sensation, which is associated with poor circulation or with structural foot deformity, they come under the high-risk category. We need to recheck them in 3 months. When the patient has history of ulcer, amputation, or the patient has a neuropathic fracture, they belong to a very high-risk group, and immediate intervention is the very need of the hour for these group of patient. So what are the different types of footwear? We need to advocate them for using. It depends upon the risk category where the patient comes to. So when a patient is in a low risk category, where the patient has got absolutely good sensation, then these are the specifications which we need to mention for the patient. They can use their footwear of their own choice, but these are the things they need to keep in mind. So the first is the shoe width, where whenever they buy a pair of sandals or buy a pair of footwear, the toe box of the shoe should be broader enough. It should not be narrow enough. Only when it is broader, the patient will be able to move the toes freely. The patient will be free from the hallux valgus deformity. The second is the shoe length, where when the patient has to buy the shoes, the ideal shoe should be in such a way that it should be at least 1.25 centimeter longer than the longest toe while standing, so that the patient will be able to walk freely. The third is the patient's footwear should have a good shoe depth, so that there is enough amount of toe space, and the upper portion of the leather will not lacerate the skin of the patient over the dorsal aspect. So these 3 important specifications has to be made to the patient, that the shoe width, length, and depth of the footwear must be proper enough, so that the footwear doesn't cause any problem for the patient. When the patient has absolutely loss of protective sensation, they belong to a moderate risk category. So for these group of patients, we recommend something called as MCR. MCR is microcellular rubber. It is a rubber material where pockets of air is introduced into the rubber material. Because it is filled with air bubbles, it gives a even pressure distribution, and also it gives you a cushioning effect, so that the pressure is even everywhere. That is the ideal footwear which we recommend for a diabetic foot patient. So this has got certain components on it. It has got an hard outer sole. This protects from any foreign objects which can enter and pierce inside. The second is the insole, which is made up of microcellular rubber, whereas the pressure is evenly distributed. It has got an adjustable front strap. The front strap, again, because patient can have some component of swelling, edema, so this can be avoided with the adjustable front strap. And again, most of the patients will come to us telling that when they walk, they leave the footwear and they walk because of loss of sensation. So to avoid all these things, they can use a backstrap footwear. This can accommodate the foot properly in the footwear. So these are the main components of an MCR footwear. So this is one of the in-house footwear design, which is manufactured in our prosthetic unit. So this is an MCR footwear with the back strap. And again, this straps are made with an Velcro material, so that this again doesn't cause any friction over the patient's skin. And we also make sure that the MCR footwear, which is designed, has got a broader toe box to avoid the allex valgus deformity. It has got a good space so that the patient will be able to move the toes freely while they walk. This is a footwear called as an MCR footwear with heel counter. This is another model of the MCR material, but sometimes patients prefer that they want a footwear like a shoe. So it resembles like a shoe where it has got an heel counter which can hold the heel in a proper position. Some patients, when we look into the MCR footwear, because of the color, because of its texture, some patients will not like to wear the MCR footwear, or the occupation will involve them to wear the shoes. So for those type of patients, we can recommend them to use silicone insoles. This is a commercial product which is available in foot care products, or it is available online as well. This is available in different shapes and size as well. So this insole can be slipped inside the patient's footwear. And again, this gives a durability, and the pressure distribution is also very even in this insole. And our customers, like when the patient goes to the temple, again, what they do is they remove the shoes or the footwear or the sandals which they use, they keep it outside and then enter it. There are many instances when the patient, after going to the temple or going to the pilgrimage, they come with a thermal injury. So we have looked into it, and we have made a material called as temple socks, where inside the cotton socks, the MCR insole or a silicone insole can be kept inside, so that this gives them a temporary protection, but the thermal injury or the burn injury can be prevented. Again, because of loss of sensation, they don't even know that they have landed up with the injuries. And when we go on to the iris category, this is where when the patient has loss of protective sensation, which is associated with deformities or with poor circulation. So for these category of patients, some kind of custom-made modifications has to be given for them. So when a patient has got an hallux valgus deformity, where the first toe is moved towards the second toe, we could see that the toes are crushed together. There is no enough amount of space in between. Fungal infection is a possibility for these group of patients, and the pressure is exerted over the second metatarsal head. Even though we give them we remove the callus, we teach them the daily dressing, unless the pressure is relieved from this area, this will be recurring again and again. So to avoid all these things, we have formulated there is something called a silicone toe separator, where the toe separators can be inserted between the first and the second toe, so that the anatomy of the foot can be maintained and the pressure can be relieved in the second metatarsal head, or wherever the pressure is exerted, the pressure can be relieved, so that the patient is free of callus or free of ulcer. The next one is called as the bunion shield. Again, when the patient has got a bunion, when they wear an inappropriate footwear, the footwear can cause some amount of friction or laceration. So to avoid this, we can use a bunion shield, which again is made up of a silicone material. And again, when a patient comes with a callosity is nothing but an hyperkeratosis, where the patient, because of excessive pressure, patient tries to walk or exert more amount of pressure. Because of excessive pressure, patient's skin can become very thick. They can develop a callosity. And when these callosities are not taken care properly, or a proper footwear is not given for them, the patient can come up with an ulcer in the future. Many times there are instances when we remove a callosity, we find a stone which is sitting beneath a callosity, or patient will have an hematoma, or patient will have an ulcer beneath the callosity. So always it is very important to remove a callosity and see what is there, and make sure that we give a proper footwear so that the pressure is relieved from the callosity area. So what do we do for this? Is we give something called as a microcellular rubber with a 4-foot rocker. Usually the footwear which we use, the outer sole of the footwear is totally flat. So when we try to walk with a flat footwear, we generally give more amount of pressure. But in this footwear, we can see that there is a mild elevation in the forefoot area. Because there is an elevation in the forefoot area, when the patient tries to put the pressure, there is a smooth rocking motion from the heel to the toe. Thereby, there is pressure reduction which is occurring in the forefoot area. So the push-off cycle or the take-off cycle will be very easier when a rocker is given for a patient. And ultimately, this helps in reduction of the pressure in the forefoot area. So this is again our in-house anterior rocker, forefoot rocker designs. So this can be given for any patient who is having a callus in the forefoot area. And for patients who come with very high-risk foot, either they can have an amputation or an ulcer or a Charcot foot deformity. So this is one of a patient who has come with a ulcer in the forefoot area. Some patients, they would have purchased a footwear a month back. They would have landed up with a forefoot ulcer. When we advise the patient to change the footwear, they may not be very, very willing to change the footwear because they have invested so much on the existing footwear. So what we try to do is we try to make some kind of modification in the existing footwear so that the pressure is relieved from that area. And again, patient is also not investing so much. So this is something called as this patient was using his own MCR footwear. So what we did is we did something called as a scooping. Scooping is nothing but we take a small layer out of the footwear. Like say, for example, if the patient has got a forefoot ulcer in the greater toe, so when the ulcer is the area where the pressure is there, like say, for example, if the patient is using this kind of footwear, a small portion of leather is taken off so that there is an hollow space which is created. So when the patient walks, the ulcer doesn't directly come and touch the ground level. The pressure is relieved and the pressure is redistributed to the other areas. So this is one kind of modification which we do it in the existing footwear. So this is called a scooping. The next is something called as a metatarsal bar. Again, with the same existing footwear, we attach a piece of leather in the outer sole of the footwear. This metatarsal bar is placed just proximal to the ulcer of the patient. So because it is proximal to the ulcer, again, there is much amount of pressure reduction which occurs in the forefoot area. And again, all these works when the ulcer size is very small. When it is less than 1 centimeter ulcer, we can go for a scooping or for a metatarsal bar. But for an ulcer which is huge enough or if it is very higher, then we need to think of any the different types of modification. When a patient has got these kind of forefoot ulcers, which is more than 1 centimeter, then we go with MCR with 20-degree forefoot rocker. Again, there is a elevation which is given in the forefoot area. When the patient walks, there is much pressure reduction which occurs. This again helps in healing, ulcer healing. There are instances when the patient can come with different types of ulcers. The difficulty ones are like when the patient has midfoot ulcer, when the patient has heel ulcer, then we need to think about different forms of offloading. One thing what we have learned from our foot clinic is theoretically when we tell that this can be given, we try to follow that. But practically the patient can come up with so many problems. So what we do is we check whether this is working out. If it is not working out, we make sure we plan as a team. We try with a different modality so that that works out for a patient. These are the theoretical things which we are telling, but practically whatever is helping the patient, we need to plan on that. Because ultimately patient is the one who is going to use it. So we need to make sure that the patient uses the footwear. And there are one more instances what I would like to share is we need to check the footwear when the patient comes to our clinic. Because whenever we give the footwear, the durability of the footwear, when we would have given the footwear some 2 months back, but the patient would come with the brand new footwear. So when we check with that, we feel that the patient has not used the footwear properly. Again, we tell them to use 2 pairs of footwear. one inside the home, one outside the home, so that the compliance is also addressed. So for these type of ulcers, midfoot ulcer, heel ulcer, we give something called as a total contact cast. So a total contact cast has given us a healing rate of about 90%. TCC has to be worn for at least 6 to 8 weeks together. A TCC can be applied when the ulcer area is very clean, it is not exudating very badly. The next thing is the patient has to be following up on a weekly basis. If the patient is willing to follow up with us on a weekly basis, we put the patient on a total contact cast. And we have also found out that patients are benefiting with this total contact cast. So this is a patient with heel ulcer with a 3 or 4 sittings. The patient had got a good healing result with the total contact cast. If you could see, there is a bowler iron which comes along with the total contact cast. So after applying a layer of plaster of Paris, we do attach a bowler iron, and there is a rubber material which comes beneath. So this is again ambulatory for the patient. So when the patient can walk, ulcer healing also occurs because the ulcer doesn't come in contact with the ground level. And for the opposite side of the foot, we make a footwear correction also. So this also gives us a good healing rate. And for patients who have undergone surgery, like when a patient undergoes a ray amputation or a transmetatarsal amputation, there are other modalities as well. We give them walker, axillary crutches, or we tell them to use a surgical shoes. And for a patient who has undergone transmetatarsal amputation, we have advised this patient to use walker, plus we told them to use a surgical shoes. So when the patient who is using a walker and simultaneously a surgical shoes, the healing was there within some 2 to 3 months. And again, we have attached a metatarsal bar in the surgical shoes because the front portion also has to be offloaded properly. And this is again a common deformity which is seen for our diabetic foot patients, a Charcot foot deformity. It is also called as bag of loose bones, where this condition causes weakening of bones and the bones could fracture and the foot can take an abnormal shape called as a rocker bottom deformity. When we don't intervene the rocker bottom deformity or the disease condition in progress, this can lead to even more worsening in deformity, disability, or even the patient can undergo a amputation. So we advise on offloading measures for the patient who has Charcot foot deformity. Before giving the footwear or an orthosis, we check on the ankle joint stability. If the patient ankle joint is stable, we go with something called as molded insole. Molded is nothing but it is molded according to the shape of the patient's feet. So when the patient is using the footwear, the foot and the footwear will work as same unit. It will not work as two separate units, so that the pressure is totally equal. And when a patient has got an unstable ankle joint, we would like to immobilize the ankle motion. So we give something called as ankle foot orthosis. So these kind of orthosis, when it is given to the patient, we need to educate the patient to wear it properly, because we need to tell them that this can take care of the deformity, but it will not cure the deformity, and it can avoid the progression of the deformity. So as nurses, we play a major role in mainly doing a foot examination. Educating the patient is very important. If the patient has a wound, then removing the callosity periodically, teaching them how to do a home dressings, and also ensuring that they wear a proper footwear. And also we need to counsel the patient, because they come up with so many issues, so much of financial issues, and they will not be able to do it properly. All these things has to be addressed with good counseling and psychological support. To conclude, I would like to tell that the best thing is to prevent. So we need to make sure our goal is to prevent the categories of 1 and 2, the moderate risk and the high risk category, so that they don't go into a very high risk and then they don't undergo an amputation in the future. And I would like to acknowledge our consultants and registrars in our department and our neighborhood departments who help us so much in helping us in the foot clinic, helping us to decide an appropriate footwear for our diabetic foot patients. Thank you so much.
Well, thank you so much for that excellent presentation. And again, the clarity of your presentation. And quite clearly, your expertise is also, your professional expertise is also coming through. I was particularly interested in, I've made a few notes here, so I hope I can read my own writing. It's not always easy. But in relation to the detail of the footwear that is available and how you assess it, who actually pays? I mean, does the person with diabetes who has these complications, and particularly in relation to early interventions where you may redesign shoes and so on, how does the person with diabetes meet the cost, or is this part of the health service provision?
No, ma'am. It is like the patient would pay for the footwear, but we do assess the economic status of the patient. If the patient is not affordable, or the patient is not able to pay for it, we also have a system where we give a concession for the patient to get the footwear.
Okay, because that I mean, I am very much aware of the cost of these very specific high design or almost couturier design shoes for the individual with diabetes. And also, you very interestingly, you mentioned the socks, and again the sensitivity in relation to culture and religious beliefs. This is hugely impressive. One of the difficulties we perhaps have here is trying to persuade men that they really need to change their socks every day, whether they have diabetes or not. I don't know whether you experience that practical thing. Probably if they have a wife or good friend who would persuade them, but it is quite a problem. And even if they have holes in their socks, they seem to think it is of no consequence. I don't know whether you have experienced that. And although it sounds funny, it's actually quite important. I think we would agree. The other aspect is, I suppose, with regard to the Charcot joint, and as we know, it's not just the foot that experiences Charcot joint. Do you address Charcot joint of the hands, for example, because that is not uncommon, but we sometimes forget about it. So that was another question. And within the curriculum, and this is where our professors and academics in nursing might be able to help, how are you able to influence the subject of diabetes within the curriculum of undergraduate nurses and postgraduate training? I think maybe Professor Sharma or Rajasari might come.
Yeah.
I'll think about it.
I can take it up.
Thank you.
Fortunately, we teach our undergraduate students about per se diabetes and its complications, and prevention of the foot-related the complications of diabetes are taught, but the kind of footwear to be used, different interventions to prevent the foot complications are just taught in a very comprehensive manner, considering the limitation of hours we can spend with them. In post-graduation, unfortunately, we have only medical surgical nursing as a postgraduate specialization, and within that we have sub-specialization, but endocrinology and diabetes has not yet taken up a specialization in India. Only the certificate
have a real
course.
Opportunity now. This is your time.
Yes, and I think we have taken a commitment now, and in my institution, we will be soon starting a postgraduate program the master's program in
Right.
diabetes and endocrinology nursing, and that will soon happen in next coming academic session.
Well, that's very encouraging news, and I might suggest that you link with Professor Angus Forbes, who is the then professor in diabetes nursing at King's College, the faculty of Florence Nightingale and faculty of Florence Nightingale nursing and midwifery at King's College. And we do have a master's program which is fully funded by FEND. We also have a PhD program and a postdoc program, and again these are fully funded by FEND, because this sharing of experience, of knowledge, and particularly evidence-based knowledge and practice, and the recognition that nurses bring in terms of their specialty, interest and practice is hugely important. I'll stop talking. I just want to come to Professor Jacob for one moment, because reference has been made by the expert nurses here of interdisciplinary working, and that's good. But sometimes it is now recognized, at least here in Europe, that while you can have interdisciplinary nursing in theory, often people are working still in silos. Are you addressing that in India? Is there mutuality of recognition of the specialists in the different, coming from the different disciplines, or is it hierarchical?
I'll take that question. I think it all depends on how we train. And I think one of my good fortunes have been I've been trained in Vellore, where nurses were right from this time before I knew anything about diabetes. I was working with nurses who knew a lot more about diabetes. You saw that they know a lot more about the feet before I knew anything about the feet.
I'm sure, yes.
So that's how, to me, I mean, working without nurses becomes an issue. So that's the first thing when I came back from Vellore, I came to Ludhiana. The first thing that I thought about was I cannot work without the full team. I mean, you cannot work alone.
Sure.
So again, I think that is happening slowly, because most of the younger registrars, most of the newer endocrinologists are working in teams, and they have seen the benefits that they get in teams. The older endocrinologists may not have seen that happen, so that there is a certain resistance from that side. Yeah. But I think with younger endocrinologists, there is a lot more, collaboration happening, and a lot of work that happens in team. So I think while we go on to the panel discussion, I'll just briefly introduce the panelists, because we've not had an opportunity to for the introduction. I think I'll start with Etino, who's from Kenya. She's a clinical officer with over 20 years experience in health education, clinical medicine, and public health in sub-Saharan Africa. She's the African project coordinator for the Champion project currently. And I'm not sure what that project is. I'm sure she'll let us know what it is. She is a bachelor from Kenya itself. She has a master's degree in public health from the University of Cape Town, South Africa. And she also has a fellowship in diabetes from the University College of London. The second panelist we have is Dr. Felix. I'm sure you have been introduced previously. He's an associate professor in the Department of Endocrinology, Diabetes and Metabolism. It's the same place where I trained, which is in Vellore, Tamil Nadu. And he works with these two brilliant nurses who spoke previously. He also has interest in offloading of the diabetic foot. He is an author of a book called The Endocrine Atlas, which has a lot of pictures of all kinds of endocrine disorders. Dr. Rajeshwari, you have met. She's an assistant professor in the College of Nursing at the All India Institute of Rishikesh. She's a PhD in nursing. Her main specialization is in community health and occupational health with maternal nutrition. She's also been quite a bit of research experience working in various ICMR, which is the Indian Council of Medical Research funded projects, WHO funded projects, and NIH funded projects in various capacities. And she's currently now working at AIMS Rishikesh with, I'm sure you've all seen Professor Suresh Sharma, who is also a PhD in nursing. He's also registered in 2 countries, 2 continents. He's a registered nurse in India and also registered in the United States. And I'm sure you will understand that he's quite astute, and he's been in the forefront of trying to bring endocrine nursing into a little more prominence, and he's been the host of most of our endocrine webinars. And I think now we'll go back to the panel discussion, and I'm sure our panelists, I'll start with Etino. We wanted to know a little bit about your champion project, and how are things different in Kenya compared to what they're doing in Vellore?
Okay, the Champion Project. Thank you very much, Juma. I'm glad to be part of this webinar, and especially to see the big difference that nurses are making in terms of giving context-appropriate care to people living with diabetes in India, and also with a cultural sensitivity. I'm especially happy to note the kind of appropriate technology that is quite affordable and is applied appropriately in care of the diabetes food. So I'm glad to be part of that experience. I'm currently working in a project called the Champion Project. It has nothing to do with diabetes. It's about heat stable carbetocin in preventing postpartum hemorrhage. Yeah, but really glad to be part of this. Thank you.
So I think, Felix, you have a lot of interests in diabetic food, and I think you take care to some extent of the diabetic foot clinic as the physician in charge. Would you like to tell us more about how things have changed? I mean, I've been in Vellore about 15 years back, how things have changed in the last 15 years in terms of the amount of work that the nurses are doing. I can see that they are doing much more than what they did 10 years back.
Yeah, so thank you, Bharati and Flori, for the wonderful presentation. I think I just won't take much of time. I think the last 10 years, the sphere has shifted to a thing that we gone into a mode of integrated diabetic foot clinic. It's been run by endocrinology, a PMR physician, a surgeon who is dedicated on a diabetic foot, and a vascular surgeon in addition. And obviously the cornerstone is actually the nurses, because our numbers of nurses outnumber the doctors here, because we have 13 nurses working with us, especially in diabetes, out of which 1/4 are trained in diabetic foot. So that means 4 to 5 nurses are with me right now in the diabetic foot clinic. And the work now is towards saving a limb, because that's the motto of our clinic, because the main aim is to prevent amputation. So after we have this integrated foot clinic with this pattern, and actually the work has been mainly done by our nurses, because from the foot care examination to the training the patient on daily dressing and callosity removal, it's all the nurses do a great job in that. And physician role is to have coordination in such a way that patient does not go for an amputation. So if I briefly mention that we have 2 clinics, one in a peripheral center and another in this secondary health center, which is actually another campus of CMC, where we found that over last 6 months, there were only 1 amputation in compared to 5% amputation the previous 6 months. That means we are actually prevented 4 amputations over the last 6 months in a secondary health care center. We don't have an exact number in the tertiary care in Vellore campus, This is I'm talking in the Chittoor campus, and the main role of the nurse is enormous, because they also teach the patient to have a proper foot care at home, as well as the teachers do a daily dressing back home when they, because we ask them to come once in 2 to 4 weeks. So it is actually, I would suggest this nurses play a major role in the prevention of amputation compared to the what we had 10 years back. And so I would say that it is actually a achievement that we were able to save few limbs, because it is a problem for many of the patients.
Thank you, Dr. Felix. And in contrast, in the United Kingdom, most of that work would be done by podiatrists. And I mean, unlike the United Kingdom, we really don't have too many podiatrists. In fact, we have very limited number of podiatrists. We don't have a school of podiatry, in the sense that we don't have a council for podiatry as of yet. So that is why podiatry is more of a self-certified podiatrists are all what we have. So unlike the United Kingdom, where most of this work would be taken by podiatrists, so what do you think, that should we continue with concentrating on nurses looking after our foot, or we should try and encourage setting up podiatry schools and things like that?
Professor Jacob, you're really testing my diplomatic skills here.
Yes.
I think that really whatever works in your country, and from the demonstration and the obvious expertise of my nursing colleagues who presented here today, and if that is spread throughout, then I don't see why it would be necessary to establish podiatrists. But history may teach us differently. I mean, in the United Kingdom, for example, we didn't have dietitians 40, 50 years ago. There were nurses who became interested and specialist in nutritional management of diabetes, and then it grew into a discipline and profession in its own right. So I don't really know, but clearly the examples that you have given here today, and presumably you would have an ambition to grow this across your whole healthcare system. I know it's a vast continent or subcontinent. However, that would be very important. So in answer to your question, therefore, the clinical technical practice of your group is not applicable now because we have podiatrists. However, what doesn't change is the examination of the foot in the first instance, and making sure that that is checked on a regular basis and people know how to examine their feet, or their relevant family or friends if they are unable to do so themselves for any particular reason. There are other differences, I think, that of course, and I don't know how it is in India, but the profession of nursing and the specialties in their own right are licensed autonomous. So you first of all have to be a general nurse, and then you acquire these other specialties depending on the interests. So here in the United Kingdom and in Northern Europe as well, nurses now prescribe by law. So they are making quite significant clinical decisions, and for which they are responsible. And so they, legally and otherwise, professionally, and they can make those decisions on their own. That, of course, took about 50 years to reach to this elevated situation. Not every nurse wants to do this, and that's fine. But if you wish to proceed in becoming a licensed prescriber, then you have to undergo a further 3-year program of training, and it is very, very rigorous. Now, that may not be necessary, but I listened very carefully to what Felix said. He said he has 5 nurses, but there is 1 doctor. So, and there are more nurses than there are doctors. That's true anyway, globally. So it may be that over time there will be a changing move of the sharing of responsibilities through proper training and legislation. But you may not be ready for that yet. And I do not wish to upset any professional discipline in India. But I would say that you have more to give us by way of what has been demonstrated here today, to share with us. And I think perhaps at international conferences, you might need to push and support the not yourselves the role of the nurse in this context, but in other contexts of diabetes management, so that they can do it themselves and be invited as international speakers. Because once you're recognized, that begins to change the face. It doesn't diminish in any way the other disciplines in the team. In fact, it probably demonstrates a very enlightened 21st century approach to the management of diabetes. I would say that, wouldn't I?
I think the Indian government is also looking towards nurses being prescribers. So I'll ask Dr. Rajeshwari, what do you think, and where is it right now, and where do you think how many years it will take before the nurse prescribers will be available in India?
Actually, it won't be very long. I think because already today's newspaper, it was there like very soon we are going to have nurse prescribers too, because we will be getting the rights to prescribe, and nurse practitioners, we are going to incorporate nurse practitioner curriculum in our own system, and we are going to do that. So it's not going to take long. So maybe in a couple of years, we are going to have it. And in our own institute, we are planning to have the nurse practitioner courses started, family nurse, health nurse practitioner, geriatric nurse practitioner, and then as sir said, endocrinology nurses. So we are going to have it very soon. We're going to have the specialization very soon.
That's very good news nearing World Diabetes Day, I can tell you. Thank you.
Thank you so much.
So I think we are now 8 minutes beyond our time. Suresh, do you want to sum up our discussions for today?
Yes, I can do that. Before summing up quickly, I just wanted to tell that since I was the part of this commission, we are bringing a new commission, that is National Nursing and Midwifery Commission bill. And this bill, we are hoping to be passed in winter session. And our target is to pass it within 2020, because this is a year for nurses and midwife. If it passed, then Indian nurses will get prescribing rights. And then we will have not only master's program, but we will have DNP programs, doctorate in nursing practice. Doctorate in nursing practice, because we have only master's and PhD, and PhD is more of academic degree, and then they go into teaching. But we will have master's program in different specialties. We have in many specialties, but if I talk about endocrinology and diabetes, we will have master's program, and we will also have a doctorate program within that. So then they will be more specialized, micro-specialized, and then they will be doing research as well as clinical practice in that particular discipline. And as Dr. Rajeshwari said, that to roll it out, I think next 2-3 years will be, and for us nurse leaders in country, these are the challenges and we need to take them up. And we are doing serious political lobbying to make this happen in country. To sum up our session today, we are grateful for Endocrine Society of India and the present president, Dr. Sanjay Kalra, Dr. Jacob, and entire team of today's the panel, N.A. Filton, and other team members for putting up a light on importance of diabetes and the specific per se about the diabetic foot. I was amazed the kind of work done at CMC Vellore and the contribution made by nurses on diabetes and diabetes foot clinic. And I think we need to take up this on a bigger way. And there are only few centers in India like CMC Vellore and to some extent CMC Ludhiana and few tertiary care centers where the diabetes, the nurse-led clinics or nurse follow-up clinics or the food clinics are run by nurses. And I think we need to disseminate this education and we will take help of CMC Vellore, CMC Ludhiana and other centers when we run these programs, and we want them to take up these programs once we develop curriculum so that nurses can start contributing in Pan India and the patients can be benefited who face a lot of problems as part of these complications. So once again, I thank everyone, specifically our chairperson of today's panel for taking up a time for us and motivating for us in a Filton and our other entire team for panel and speakers, specifically from CMC Vellore. Dr. Jubin, for you.
So thank you very much. I think you have thanked everyone. Thank you, Anne, for being with us. I think it's been an interesting panel discussion. 18 thanks for joining us from Kenya. And I hope this has been useful for you and for the people who are listening. And thank you, Professor Suresh, Professor Felix, Dr. Rajeshwari. And thank you, Bharti and Flori. I think both of them have logged out, but I think, and happy Diwali to everyone. And I think we're going to have an extended weekend, which is, and I hope you all enjoy that. Thank you very much.
Thank you.
Thanks a lot.
Happy
Thank you.
Diwali.
Bye-bye.
Thank you. Thank you.
Thank you, sir.
Thank you.